this is about, real-time modeling of COVID in BC. And this background slide shows our tiny little, well, no, this is Canadian, actually. The figure here is all of Canada. Canada has, just for context, about 30 million people, so it's about half the size of the UK by population, and these are daily incident cases. So we got up to, I don't know, a couple thousand in the spring, and then now we're sort of halfway up to 10,000 daily cases across the country. Okay, so early on, a lot of people were fitting curves to these cumulative pictures. So you take the total number of cases you've ever had and you start fitting models to this. And you need some key information, like the basic reproductive number, which I guess modeling talk on infectious disease wouldn't be complete if I didn't say that that is the average number of new infections per infectious case in a fully susceptible population. And it hides a lot of variability in a lot of things. The duration, how long does an infection last? How soon can people infect each other after they get infected? So is there a latent period? And how long does it take for someone to develop symptoms? So these are the really basic ingredients. And the tools which then are used to fit data like this. And this looks like a beautiful data set, but actually, if you look at it on a daily basis, it's incredibly noisy. And so these cumulative counts that you saw so many of in the early part of the pandemic, I think they really hide a lot of modeling sins, and they also introduce bias, because if you miss something early on, you're sort of always adding a contribution to your loss when you go and fit the rest of the curve. Okay, so we need these key pieces of information, and I wanted to talk a little bit about some of the work I did early in the pandemic, advising, I mean, it sort of failed, but just trying to communicate to policymakers and government, where do these estimates come from? And the fact that, you can make things up in your model, and then you can report on what your made up numbers meant for your epidemiology. But if you're making up numbers, ultimately, you're getting at what you're putting in. So if we want to answer a question like, what happens when we open schools, then we need some information about how infectious are kids. That'd be really handy. How susceptible are kids? And we still actually, many months later, we kind of don't know these things. So I'll just talk about this a little bit. I kind of separated out into 4 types of data. Aggregate data, which we're all familiar with, those cumulative curves, numbers of people by time. Individual line list data, which we never see in the public, except when Singapore and Tianjin put it out on the internet. So that's, times of exposure, who infected whom, contact data, where were they? They both attended this church event, or this person's husband went to shop at the mall and then this happened. Serological and prevalence data, which we also have only little bits of and very rarely anything about prevalence. So how much virus is there today in your community? We basically don't know that particularly well, amazingly. And then behavioral data. If you want to think about what happens when you close restaurants, you need to know how much infectious contact is happening in restaurants. And we also kind of still don't know that many months later. And then kind of thinking about, what questions could you answer if you had these kinds of data? There's some connections there. So I think that sets out a bit of context. And some of the hardest questions, what happens if we deliver this or that particular policy lever or intervention, actually depend on all of the different kinds of data. And I think there have been some data gaps. I also acknowledge it's pretty easy for us as modelers or statisticians to complain about data and say, everybody else should do a ton of hard work, need more data. It's easy to say that, but we do say it because it also is possible to communicate what the value of having those data would be. Okay, so we used public data from Singapore and Tianjin, China, which we digitized early on at a hackathon in mid-February. And they were, they weren't analog and pieces of paper, but they were like these little stories. And so we made a spreadsheet with the right kind of data frame to do this. And so we estimated the time it takes to get from infection to symptom onset. This little picture here, I guess I can zoom in like this. Each row is an individual person, and it shows the time course of their infection in Singapore in February. So they start out, they haven't been exposed, and then there's an exposure window, that comes through, who were you talking to and which event did you go to and where was, like basically boots on the ground public health, and then symptomatic, hospitalized and discharged. And they were all, I think, isolated in hospital. So it wasn't that they 100% of them got super sick. Here. So with these data, you can use survival analysis techniques to estimate some of the timing, knowing that you're truncating at the end of the observation period, which was February 26th by the time we finished this. And one of the things we found at that early stage was that transmission can happen before symptom onset. This is well known now, I think, but at the time it was rejected by 5 different top medical journals. People did not want to know. Eventually it came out in eLife, so it's published there now, this analysis. And we estimated these various timing, and by comparing them, you can look at when transmission happened and when symptom onset happened, and you can unpack that in these 2 data sets, 40% or so of transmission, up to even 80% was happening before symptoms. Of course, if you immediately isolate everyone with symptoms in hospital, that does mean of the transmissions you had, more of them were before symptoms. So, in context of what the intervention was. But that early on, I think we knew that waiting for people to have symptoms, then testing them with a turnaround time, then doing contact tracing, we will miss too much transmission because transmission happens before symptom onset, unlike something like SARS-1, where transmission happened after symptom onset. Okay, so here's the early timeline in BC. As with many other places, we had some community transmission, but before this time, we had been really watching for it, and we had a PCR test in late January, and there had been a few introductions, but mainly from flights from Asia, and people had been very willing to stay home and self-isolate. So we didn't have real community transmission until March. And then we did all the things, banning the gatherings and stopping the universities and closing the bars and closing schools. And at that time, that was already somewhat controversial. And we had this data that suggested that, about 20% of Canadians maybe didn't think that COVID was such a really big deal. So these were, let's see, this was a survey done by Angus Reid, and it asked, what people are doing and whether they thought COVID was overblown or not. And this was in March. So about 385 over 1,500, whatever that is, some portion of the population did not think COVID was that serious, and they weren't doing the distancing stuff as much. And so that led us to think about, what's a simple way to model social distancing and what we're doing. And so we did, like everybody else in the modeling community, all 50,000 of us, we made an SEIR model. So in this kind of model, you have your people who are susceptible and exposed. These guys are exposed, but they can transmit, because we know they can transmit before symptoms from our other survival analysis thing. And here they're infectious, quarantined, and recovered. And these are ordinary differential equations, most of which aren't shown, but the 2 important ones are shown here. The rates of flow out of the susceptible compartments. And the little arrows, the red ones, show infection in infectious terms. So then, of course, you see there are 2 layers of this model. One is people who are not willing or able to do social distancing. Maybe they're essential workers, or maybe they don't care about COVID. Or maybe they care a lot, but they can't not go to work, or they live in a household. Anyway, whatever. And then these are the people who are willing and able to engage in distancing, and they have a little factor F in front of their force of infection term. So new incidence infections here coming out of susceptibles moving into the exposed class are, everyone infectious, and then just susceptibles divided by the population size. So this is one of these fully mixed compartmental models. But this fraction F, creatively named for fraction, is a reduction in transmission for the people who are engaged in distancing, and it occurs twice. It occurs here because they're less likely to go out and about, and it occurs here because they're less likely to be the ones you find when you go out and about. Okay, so there's a cartoon picture of that. And the little houses are the people who are stuck inside with their laptops, like all of us right now. And then you have these, so the green individuals are the people who are willing and able to work from home, and the pink ones not. So when you go out, you see more pink ones, and the pink ones are more likely to go out. Okay, so that's a model. And from that model, we need to think about data. And we know that people, of course, do not get tested at the moment they get exposed. And testing rates change with time in a way we don't understand. In fact, we don't understand what the testing rate even is, still, amazingly. Okay, so they get exposed, they get symptoms, they get tested, and that gets reported. And there's a delay, which we could estimate using internal data, using line list data. And so we just model the expected number of cases as some convolution over the past, based on some delay that takes all of these things into account, and we estimate the parameters of this thing. Okay, so we estimated the impact of social distancing, like everybody else. At the time, it was March 25th, and we were like, okay, let's estimate this right now and submit it. And we worked really fast, and we thought it was great. And I think we weren't quite aware that every other model exists in the world was maybe doing quite similar things. But okay, so we wanted to do it for our jurisdiction, not for someone else's. So okay, so we start with our contact parameter 1, and it goes down to some estimated number, and we use a negative binomial likelihood for the case counts with some dispersion that we can estimate. And so we set up our Bayesian inference in RStan, and we loved it, and we made an R package COVID sphere, which people are still using a lot today, which is great. Across Canada, I'm using it, and so is our government and other people. Okay, so we have our Bayesian inference, and we take our posterior. We want to estimate, our R naught in the absence of our quarantine and stuff, so our kind of basic underlying R naught, the strength of distancing, the dispersion, and then in the end, we estimated a whole bunch of other stuff, and we use the case count time series to do that. And this, we use our negative binomial likelihood and our priors. Okay, and then the fit is great, and isn't that a cute curve with like 60 cases a day that we got up to, and then we went down again, and that was it. That was the so-called first wave in BC. BC has 5 million people, so we are about a 12th of the population of the UK, and you can estimate how well this ramp works, and it works great. So this is the histogram of the posterior fraction of contacts removed. So this is actually 1 minus F, which was a mistake to reparameterize that way, but that's where this slide is. And on this right side, everyone is living alone in a log cabin. And on the left side is business as usual, and we were much more towards the right side. And I think that's what, we were describing at the beginning of the call, that, Richard, you were saying, like, yeah, this works. We know that making everybody stay home works. It's something we know we can do in Western jurisdictions, and we know it works, and here's how we knew it worked in BC. Okay, and our posterior reproductive number was about 3. But there's some issues here, as you might guess. There's some identifiability problems. So we did some sensitivity analysis. We changed the model assumption about the duration of exposure and illness, and we know from theory that changes R naught. And sure enough, you can get the same beautiful looking fit with this over dispersed data, and you can look at the same prevalence about. So this, we never observed this, we observed this, but you have very different inferred R naught values from 2.5 to 3 to 3.5. And these parameters in here are parameters that we can't really measure. They're kind of like the duration of circulating infectiousness, before people really effectively stay home, and they depend on things like how many people are asymptomatic and how long does asymptomatic infection last, and is it actually infectious, and things that we still don't know about COVID. So I think based on these reported case counts, we can't know R naught. And that's important because we need to know R naught to know answers to questions like, will contact tracing ever work the way we're doing it, or how many people will we need to vaccinate? So that's an issue. But on the plus side, the fraction of contacts removed and the fact that it was to the right of the threshold and we were declining was very robust. So you could change everything about R naught, but you still get a good estimate of the effective distancing. It's good, it's still good. And that makes sense because no matter what you do, this is going to decline. So you're going to get something that looks good. Okay, similarly to R naught, the prevalence is also something we can't know from these data because we don't know the ascertainment fraction. How many of the true cases are we actually sampling and testing? And it's amazing, like we did this work in March, we still don't know these things. We know more about them. So it's a bit facetious to say we don't know. And in the UK, I think you guys actually do know more about this. But you can change your ascertainment fraction assumption. And we know it changed at a fixed time point in April when we widened testing. So we put that in the model. And you can get a robust estimate of this fraction of contacts removed. So that's wonderful, this F, or 1 minus F. But the R naught value and the prevalence can change, by a factor. The prevalence changes by a factor of 4 here, and as does it's related to the sampling fraction, of course. And the R naught changes from 2.75 to 3.5. So quite a big shift. But, yay, like we can still estimate the impact of distancing and it's still good. So that's great. This matters now because it's starting to get to the point where if you run these models for 3 months further, they turn around due to herd immunity, but they won't. Like that will depend on the prevalence, the actual prevalence, not just the reported cases. So this ascertainment fraction or sampling fraction is becoming more relevant, I think, to know. Okay, so then, there's a lot of talk of waves, the first wave. And in BC, like I said, we had this adorable little wave of 60 cases. And people were talking about, okay, like now the first wave is over and who knows what's going to happen in the fall. And we used these figures to just make the point that that was not a wave in the sense of like an SIR model that goes up and goes down because so many people become immune. That was a wave because we stopped, we put everybody at home working on their laptop. And as soon as we stop doing that, of course, exponential growth comes along and rises like a vertical wall. And there are no longer 100 reported cases, or however much this prevalence is, was 1,000 cases in BC at a time at that first quotes wave, and it just skyrockets. And that's where it skyrockets too if you use a nice big plot like this. And that was the first little wave, and that's kind of what would have happened if we just said, okay, we're done and gone back to business as usual, which we didn't do at that time. Then we simulated, as did many other groups, what happens if you go on and off with your lockdowns. And yeah, it works. Seems to work pretty well. We haven't really adopted this, I think, anywhere, this idea that like we have a planned lockdown at the end of December and then another one at the end of January. I think we're sort of muddling through. But that was something that works in simulation. Okay, how are we doing for time? Oh yeah, not too bad. Okay, so let's get to now. I made one of these, how it started, how it's going. I don't know if you've seen that meme. That was our early reported cases. And then, we had a very slow summer with not a lot of COVID and more travel. But, you could see the signs of exponential growth in July. And then this is where we are today. This was last week. So, we're growing. And I think accidentally we may have decided in Canada to go ahead and have a pandemic now that it's fall, which is maybe not the best choice. So we're seeing exponential growth here, and we've just entered BC's very minimal version of a shutdown, which I think is affecting how people are behaving. But it's basically like bars and restaurants and schools are still open. Indoor fitness is not, and we're told not to socialize with people outside our households or have people over in our households. But I think we can go out to even a restaurant with the people we live with. It's a little odd. Religious gatherings, I think, are now limited, and weddings to size of under 10, maybe. Anyway. Okay, so then we did the same thing for other jurisdictions, which is work because of all the priors you have to do to set up the model. And we estimated for different jurisdictions how far they were away when distancing happened. How far did they get compared to the threshold? So this is now F, not 1 minus F. And New Zealand, you can see their contact rate was very low and their critical threshold for growth was higher. So they had a lot of leeway. Florida did not have a lot of leeway. If they reopened, then we would expect massive rises. And of course, that's what happened. Okay, so then this work was used in BC. This is Dr. Bonnie Henry's presentation, and they, I think they used Microsoft Paint to change our blue colors to pink colors and took some of these slides. And this was used as a communication tool for the public, and I think it has a nice aspect because we can take something that is sort of interpretable in the model, this idea of the contact rate among those who are distancing, and say what portion of normal it would be at and what would happen. So it kind of tells a story about, you know, our individual choices and how they might affect COVID. And this is actually kind of what we're doing now, 80% of normal, and it's going up. But, you know, it sort of shows that there's a threshold. The trouble, of course, is that what is 50% of normal? Like, is that me having someone over once a week, or like it's not particularly practical, of course, because it's this big compartmental model, this full mixing. We also look at these sort of scenarios because we know we can't use these models to make predictions. What we can do is use them the way you use a flashlight to illuminate the cliff that that you will walk over if you keep going in the direction that you're going, and hope that that motivates change. So we do these things weekly now for 6 provinces in Canada: Alberta, BC, Manitoba, Ontario, Quebec, and Saskatchewan. And of course, they have wide confidence intervals, as you would expect. And we just look at different, you know, this is what we're doing now, the green one. What if we reopen more? What if we scale it back? And of course, you see different exponential growth rates. And it's used as essentially a tool to communicate what exponential growth actually looks like in your jurisdiction to people, I guess, public health agencies and people who are thinking about what to do in their jurisdiction and what it might look like by December. So these, I roll them up into the national forecasts by national extrapolations by resampling. So each province has its own negative binomial distribution and its own dispersion. And so to get quantiles for the sum, right, just resample each jurisdiction and then add them up and then take the quantiles again, which is a minor fuss, but that gives us a kind of Canadian level picture for, you know, if all the provinces get better control, or if they all stay the same, or if they all, you know, reopen further. This was one from September. And actually, I don't have today's on it, but this one I put in here because it came out in one of the national presentations from Dr. Teresa Tam, who's our health person. And this crossroad, they used this sort of crossroads language, which was interesting because, of course, anytime in one of these curves, if you change your, you know, it sort of said, oh, like, wow, we're at a crossroads. We could make decisions that would actually change this. And I think that's always true. But in this particular moment, that was picked up federally and sort of used for public messaging. Okay, so earlier made this, when we first did this work, we had kind of what are the next steps. One of them is, you know, what we would really like is a leading indicator for this strength of distancing, this F, or, you know, transmission, or, you know, something everybody wants, you know, what's happening today. And let's not wait 2 weeks for exposure, symptom onset, testing, reporting. Let's try to get a sense of today. So could we use Facebook's data for good, or TELUS's mobility data, or Google's mobility data, or syndromic surveillance data from 811 calls, or sorry, 999 calls, or from, I guess that's just your 111 calls, or salbutamol prescriptions. And basically none of it works. We've tried all of these things, and none of it is highly resolved enough to really predict shorter term upticks in BC. We also looked at, and this we did do, and it worked, and we found, so if there is a change in transmission, how long will it take to be able to detect that in reported cases? And the answer is too long, 3 to 6 weeks, and the parameters we had in BC at the time. It's probably 2 to 4 now, but it's not the case that you can change something and detect it right away, as I'm sure you all know. Of course, the population is not well mixed, and these models assume this sort of melting pot. They do pretty well, despite the wrongness of that assumption. But of course, we're also looking at more heterogeneous settings for modeling. Okay, things we don't know still, amazingly, in BC, and I think across the world, we are not doing a lot of population level virus prevalence testing. How many people have the virus in your community right now? We basically have some idea of that, but it's not a lot. The idea we have is probably in Wales, I think about 2% from that one big report. And in BC, I would say it's probably still 1% or under. How many people have ever had COVID? In BC, it was under 1% in May because we had our tiny curve. Those data are better now, they're more available. I think we still don't know how infectious children are and what's happening in schools, partly because we are not looking and we don't want to know. We're kind of head in the sand there to some extent. And I think children are probably not as much a driver as they are with flu, and it's probably not as bad as we might have worried about, but I think it's not perfect. Okay, and then contact patterns. So there's still a lot, and this is like a tiny list of things we don't know, kind of from a modeling point of view. Okay, so I'm going to talk about a couple of, and I'm not going to sort of go through these, but I wanted to just highlight some of the individual level modeling that we're doing. One is this cool paper that it's a bit of a win. We got this in PNAS, came out a week or two ago, and we looked at the R number, so the number of new cases per infectious case at your event. So if you have a wedding or if you have a choir practice, how many people would you expect an infectious case to be able to cause? And what happens if you put people further apart, or you make them wear a mask, or you make them stay with the same bubble of people? The strict bubbling. So you go to the wedding and it has 50 people at it, but you're only allowed to stand next to the same 5 people you came with. So it's kind of strict bubbling. And we figured out that, there are some events where the transmission rate can be so high that actually putting masks on people, reduces the rate, but it doesn't reduce the probability very much, because if the rate is really high and you wait long enough, the event still happens with reasonably high probability. And in those places, kind of strict bubbling is by far the best. So if you did want to run a nightclub today, the best thing to do would probably be to set it up into little capsules of 5 people and only let people come and dance in their little capsule with 5 others. Whereas if the transmission rate is not so high, it kind of doesn't matter. You can see 1 person for 10 minutes or 10 people for 1 minute, and the expected number of new infections is the same. So that was like a little bit more than high school math. That had like one simple little Bayesian thing in it, but it was pretty nice and like a principled way to set out what to do at your event, except that we don't know transmission rates. Okay, we also looked at some school modeling. We took one class at a time, and I'll just zoom in a little bit. These are data from Quebec, crowdsourced data on cluster sizes in schools, and these are types of schools in Quebec. Cégep is like a A-level kind of college, and most of the schools, of course, are primary or secondary, or Cégep, I guess. And it just shows, this is the real thing, and this is the one with only bigger than 1, and it shows there are a lot of exposures that don't lead to any onward transmission, and then there are some that do lead to onward transmission with cluster sizes that are bigger. So we looked at this and thought, okay, we know that transmission is variable and over dispersed, and we know that from lots of other studies. So, let's introduce a case in a class and just stratify. You have low transmission or medium or medium or high. And in the class also, we know that there could be differences according to, how loud is it? How dense is it? Is the window open? What are they doing? Are they like really jumping around all over the place, or are they sitting quietly in their little tables and only contacting their 4 little friends? And of course, if you vary those things and visualize them in the right way, you can see that the cluster size that you get is often small if you're lucky and you have low transmissibility. You get this really small, mostly no onward infection, but sometimes a few. And if you're unlucky, you get an asymptomatic index case, purple here, doesn't show symptoms. And in order to find out what's happening, what we're doing is we're waiting until somebody shows symptoms, and then they're getting tested, and then the test has a turnaround time, and then we go and we find their close contacts of only the 4 kids we think little Johnny has played with that day or that week. And if you do that, and you're unlucky enough to have an infectious but asymptomatic index case, you can quite easily infect half the class or the whole class. And so that's a problem, because even though we think transmission doesn't happen in schools, based on small numbers of index cases that were probably lucky in May and June, there's a waiting time until you get unlucky, and the higher community transmission is, the faster those unlucky events are going to happen. So we wrote a preprint about this. And I haven't talked about these interventions, but we found that surprisingly, there's not as much difference between this sort of go find the 5 kids you think your index case has played with today and test them versus stop the whole class and test the whole class. Within that class, it doesn't make much difference, because if you're unlucky enough to be in this situation, sure, all of these interventions do something and they shift the distribution to the left a little bit, but they don't do as much as we thought. And if you're lucky, none of them really matter. Like you're not going to expose anyone anyway. So that was kind of nice in the sense that this is what we're doing here. We're looking at close contacts only and advising them to self-isolate. And if they show symptoms, get a test. We're not testing whole classes. And within a class, that's probably okay. However, if those people don't self-isolate and then they go to their dance lesson or their soccer practice because they don't think they've really been exposed, then of course, they will bridge and cause other potential clusters. Okay, and then finally, contact tracing. So this was known early on, based on the getting back to the start of the talk. Transmission can happen before symptom onset. Here's symptom onset. Here's the red blob saying infectivity. So, okay, this is the index case. They infect their friend. They get symptoms. They get tested. They get test results. Public health has to find all their contacts and phone them. This is their infectee and their infectee's infectiousness. When do we stop the secondary case from infecting others? Well, we don't stop them until this time. And so this tiny shaded area here is the portion of their infectiousness that we are able to stop. So in this diagram, we stopped one transmission or tertiary transmission. And you can actually use this and estimates of the timing here and estimates of the timelines. If you know these timelines for your favorite jurisdiction, you can figure out how many cases you could ever stop by contact tracing that is initiated by a symptomatic person testing positive. And it depends how many of the cases you think you ever know, which we still don't know. And you can find that actually 40% or fewer of the contacts are going to be averted by this kind of contact tracing program, which means that if your R is less than, say, or is bigger than, say, 1.5 without contact tracing, this will never work. There's no way you can go to 0 from positive test results to contact trace. And if you're up at 3 days, where a lot of jurisdictions are, you may be getting, we redid this actually yesterday and found that they're a little higher. So maybe you're getting 10% or even up to 20% of the cases averted by contact tracing initiated by symptomatic testing. Okay, what that means though, is I think we know that most Western jurisdictions want to reopen to a level where contact tracing kicked off by symptomatic testing will never work. And so here we all are. We haven't ruled out, you guys may be different. I know you're testing a lot more asymptomatics than we are, but in, I think, Canada and a lot of the US, and a lot of other places, we have set up a situation that we now know is not going to work because we need levels of reopening for our economies and our mental health and all the other things that were damaged by the first shutdown. We need those to be reopened at a level that means contact is high enough that this approach with this delay will not work. We have to be testing the contacts here or here at the time the initial case is tested. If we could test all the contacts instantly, even if we tested all the contacts here instead of sending them home to self-isolate, that we would do much better. But if we have a turnaround time for the test, this is not particularly feasible. So I think I'm heading towards more what Taiwan is doing. We need to be testing all asymptomatic and symptomatic contacts and supporting people to isolate without sending them home entirely to isolate. No one wants to infect their families. So I think we're in a mode where we need a different approach because we know that we want reopening to be strong enough that probably this kind of contact tracing won't work. Okay. This is work that's been done in collaboration with the BC CDC, the British Columbia Centre for Disease Control, My group at SFU and Dan Coombs' group at UBC have participated in that modeling team. My colleague Paul Tupper made the figures and has really led the individual-based work, and we're funded from Genome BC and the Michael Smith Foundation for Health Research, as well as the Canadian federal funding sources. And I want to do a shout out to Sean Anderson. He developed the COVID Sphere package, which people are using, and made those plots at the beginning, the first whole modeling talk, based on my model from the social distancing model. And he's a statistical ecologist based at the Department of Fisheries and Oceans. And he and his friend Andy kind of jumped in and volunteered with our team for months, and it was great. And it kind of made me realize the connections between thinking about estimation and modeling for very hard to observe hidden fish populations that you only see when they pop up, and hard to observe virus populations that you only see when they pop up in your reported tests. So that was a fun link there, and he's fantastic. Okay, thank you.